a young father was lost, and that is highly traumatic. I've spoken to the family and I apologise to them on behalf of the South Australian government.
Last month, a 47-year-old South Australian man, known only as Andrew, called an ambulance after pulling over to the side of the road with jaw and chest pain. 41 minutes later, paramedics finally arrived. It was too late. Andrew was dead in his car. A new report into his death is damning.
Had a paramedic crew been with Mr AR at the time of his cardiac arrest, he may have been successfully resuscitated at the scene.
Sadly, Andrew's death is just the latest tragedy to come from the nation's overstretched health systems.
The risk of adverse medical outcomes always goes up when there are greater delays, and the fact is, around Australia, there are more delays.
New figures out today show 1 in 10 patients at Sydney's ED are leaving without treatment. That number, a whopping 67% increase on 2019.
It's a sign of a system under duress and of patients in distress. It's an enormous source of worry for doctors and nurses in emergency care. It tells us that we can't do the job that we would like to do.
In Victoria, 33 people have died over the past 2 years because of 000 call time failures. And today, a cancer patient has revealed she was forced to travel 1,600 kilometres to Adelaide for a brain scan because there were no MRIs available in Melbourne.
We were gutted, to be perfectly honest. The stress and everything has put an enormous toll on us. I just think it's disgusting that our health system is being run down to such a state.
2.5 years of COVID have ground down already battling healthcare systems, with staff shortages and burnout, ambulance ramping, lack of beds and a lack of access to primary care all to blame. So what will it take to bring our healthcare system back from the brink?
President of the Australian Medical Association, Professor Steve Robson, is here to give us his thoughts on this. Professor, most states are promising more healthcare resources to try to deal with these overstretched systems. Is it as simple as that, though, just throwing money at the problem?
I don't think it is as simple as that, and you need to step through why ramping happens. If you can't get a sick patient out of the back of an ambulance into an emergency department, it means that the emergency department is under-resourced and overstretched. It means that patients who are in an emergency department who need to be admitted to a hospital don't have the physical resources in a hospital to get them out of the emergency department. And it means that hospitals who are trying to discharge patients to the community don't have community resources, whether it's aged care or general practitioners who can look after patients when they leave hospital, or the NDIS. So ramping tells us that resources at every level, from the community through to general practice, through to hospitals, have reached capacity, they're beyond saturation, and it's a thing that's crept up, and just throwing money at it avoids the problem that it's a system-wide issue.
It's also the bits before you get to hospital, right? So primary care, people going to GPs and not being able to, and then going to hospital, things like that. If you had to apportion it, what percentage of it would you say is hospitals not functioning properly and not being properly funded, and stuff outside hospitals that needs to be attended to?
I think there are issues on every front here, and you've hit the nail on the head there, that one of the big roles of primary care and general practice in the country is keeping people healthy in the first place. It is resources within the hospital, and that means staffing, physical beds and space, but it also means all those other resources beyond discharge. Going back to general practitioners, having somewhere to live, having someone to look after you. So I think there are equal parts of the equation everywhere, and they all need to be dealt with if we're going to solve the problem.
Well, the government's already said it'll commit $1 billion to a Medicare task force aimed at improving GP affordability. What difference will that make?
So the government's committed around about $800 million over 4 years. So it's going to equate to a little over $200 million a year. If you think about all the patients around the country and all the general practitioners, it's going to spread pretty thinly, pretty quickly. So we think that money is helpful. It's a start. But as you can imagine, the system Australia-wide needs a lot bigger injection of resources and funding than that alone.
You've said it's not just about money, but as I listen to you, all of the things you're identifying, it seems to me, are about money. Can you identify the non-money things that are necessary here?
The key thing is workforce, and we have a workforce that's under immense pressure at the moment. So you can have all the money in the world, but if you don't have nurses, if you don't have doctors, if you don't have physiotherapists and all of the people who provide healthcare, the money is fairly meaningless. We've got to look at the workforce that we have, see how we can make them more productive with technologies like telehealth and so on. And we certainly need to look at migration, but we need to look at migration in a selective way that doesn't disadvantage other countries that also need healthcare workers.
Steve, there's a lot there. There really is. Appreciate your time.
It's a pleasure. Thank you.